Disadvantages of being on the pump. There are the disadvantages if you're not compliant. That's quite clear. Okay, so he always wants last lists. But last time you did go, we did. Yes.
I was going to ask you if you would mind saying who you are and what your role is here, please.
Oh, those pesky introductions.
I apologize.
Jerome was
very sorry. Jerome.
Yeah.
No.
This is Dr. Sobel. And,
I apologize. No, I usually do that, and please come in. We have plenty of chairs.
Sure. Okay.
I'm going to start all over again right now.
No,
That's the first thing I'm supposed to do.
I've been standing on
You've
here.
been with Medtronic.
Yeah.
Okay. My name is Doug Sobel. I'm a pediatric endocrinologist. I've been here at Georgetown for a long time, for 24 years as a pediatric endocrinologist. And I practiced somewhere else before here in Bethesda. And I'm head of the pediatric diabetes program. And Dr. Sharifat is another pediatric endocrinologist who's working here, and some of you may know her. Jane is our nurse, pediatric endocrine diabetes nurse, and we're having a new addition, Seema, who is coming, who is who'll be our new nurse practitioner for diabetes. So we have a group of the clinical group, and then we also do research here. My research, my main interest is finding out how we can treat someone who is going to receive an islet cell transplant with not so much all this toxic medication so they can keep the transplant. And right now the state of the art is you can't. Even with the triple dose therapy, the transplant only lasts for a year maybe, and then you need another squirt of islets into your liver. It's not a simple thing to do. So that's been my interest. We've done work on treating new onset diabetes, and we just got a paper accepted on treating children who've just developed diabetes with different low-dose immunotherapy to extend what they call the honeymoon. So your sugars you're hardly on any insulin. We had 60% of our patients off insulin, and we have maybe 1% of our patients off insulin for a week or two or three. Now we had 60%, which was exciting. So we're interested in some research, and we're also planning, when the nurse practitioner comes, to start up this other project which relates to how to utilize the continuous blood sugar monitor better. And right now the data shows if you have a continuous blood sugar monitor, it helps you reduce your hemoglobin A1C, but not as much as one would expect. And so we're working with some people at NIH and myself, and Dr. Sharifat's the lead person on this, to try to figure out how to do better than what's going on. I'm giving you more than what you asked for, but you know. So, and the other thing that we do, and then it'll be your question, is that we know that the system, the medical system, we're not talking about the new health bill. I'm talking about what you got now. It's not going to get better. But what you got now is that you don't always get to see a nutritionist for free. You don't get a youth group. You don't get a network of people that you can talk to, particularly if you're new onset diabetes. And you don't get necessarily the hospital putting on these seminars. It's from you, basically, volunteers, and the Diabetes National Institute that help us do this. So we formed a group where we want to do things, and people decide, hey, we like to do this or like to do that, and we try to do it, which is outside the whole healthcare stuff, which is not going to get paid for. So you'll see we'll have some free nutrition, individual or small group counseling in May. I think we're getting a date for that. So we're trying to provide these things to help people who have diabetes in their families. So I'm Doug Sobel. It's short. Yes, sir.
Can you talk about the prerequisites for going on to the pump versus?
Excellent. That was the prerequisites for the pump depend upon your endocrinologist, who you're dealing with. So I would say, in general, The prerequisites would be that, one, that the person who's going to be on the pump is compliant in testing for sugars and doing what they have to do about diabetes and being an expert in carbohydrate counting. It's not mildly compliant, that's compliant. Who can demonstrate they can take 5 to 8 blood sugars a day routinely, know their carbohydrate counting really well, and learn or have the parents know all this, and the parents, of course, or the child who's going to be in charge know how to deal with the pump mechanically. Once in a while, so this is, you're talking about school, and having someone responsible in school, or the parent going into school, or somebody in the school knowing that they're always going to be there for lunch or for a snack. So the pump, it needs the attention each time there's going to be carbohydrate ingestion. And you need someone compliant to do all those things. And you have to be comfortable that you have a pump in you. And of course, each time we order a pump, we have someone on it. I like to have someone on it longer than others, 1 or 2 weeks, just to feel that it's okay to have this, well, depending on which one you have, but the pump that was ordered, that you feel comfortable with that. And it's just putting saline in, and we can play with it and work with it. So, so around those issues, your endocrinologist will be talking to you about them. What else? Good question. Yes, sir.
I'm on a regimen of Lantus and Humalog, and I was wondering what kind of dosage conversion there is going to basal and bolus.
Oh, we're really not, I apologize, we don't address that, some of the things
Okay.
which are really related to your endocrinologist.
Okay.
But you will see that it's going to be very similar.
Okay.
That your Lantus dose will be similar in the very ballpark of the 24-hour basal that you're getting.
Okay.
And the regimen of, as you're doing right now, of how much to give per, 1 unit per 7 or 8 grams of carbohydrate won't change that much.
Okay.
And the correction factor, which you probably have like 1 unit for every 25 milligrams percent or 30 above your goal, may not change that much too. But again, it's a more clinical stuff where you don't want to, step on anyone's toes. Everyone has a little different way. Yes?
Do you usually do the basal bolus before you do the pump? Is that the
Everyone's
solution?
different. Everyone's different.
You don't just jump to the pump though, correct?
Jump from NPH?
Yeah.
Yeah, some people do. Has everyone signed this? Or who's not on it?
I don't think we've done that. You can-
Okay, may I give you that and then pass it? Anyone else besides you two? Thank you. And if you want any email from us about the different activities that are coming up, put your name down. And again, this is the big party, which is a lot of fun. All right, so we.
Another question.
Sorry, one more thing. I just wanted to ask you, when you mentioned when you were doing your introduction, you said about newly diagnosed patients and like trying to extend the honeymoon. Is that right when you're admitted in the hospital, or what is the time frame of getting onto that program?
The protocol is finished, so you can't get on it, but it was within, I believe, 4 to 6 weeks of being diagnosed. But there are protocols for newly diagnosed people with diabetes relative to GAD, you might have heard, and relative to antibodies to T cells. Those are the 2 main ones that are around right now, and that can be found. And I can try to give, if you want to email or send me something, I'll try to, or call me and I'll try to get you that information. But the websites are pretty readily available for those studies.
Is this GAD as in generalized anxiety disorder, or is this something else?
Well, that is true too, but no, this is glutamic acid decarboxylase, which is a protein that's in our brain and pancreas. And it was thought to be important for the development of diabetes. Development of diabetes means that your immunologic system, which is one kind of cell, lymphocytes, get sensitized to this, and they start attacking, or directing the attack, I should say, of the cells that make insulin in your pancreas. But you're right, GAD is certainly, your GAD is certainly prevalent in diabetes. So we were supposed to have, we only have 2 representatives, supposed to, 3.
Medtronic.
Medtronic, great.
Yeah.
So actually, so we're only down 1. That's pretty good.
What's the one you're missing?
We'll talk about that.
Okay.
Hold on. So you want to do it in order of coming. So let's do second and third. And you have about 10 or 12 minutes to talk about your product. And I would suggest not talking about using why the pump is so good for diabetes, but talk about the pump specifically.
And Dr. Sobel, I think we're going to hang around a little bit afterwards and then
Yes.
come in and...
Yes, and you'll be able to look and maybe even play with some of the devices. All right? So, all right.
Thank you, Dr. Sobel. I'm Aaron with Insulin, and we make the on-the-pod insulin pump. Mary Ellen